So thank you all so much for having me. Again, my name's Eric Goodman. I'm from hospital medicine here at Mount Sinai. And I just want to quickly give an acknowledgement to the residents that I worked with on this project, Sarah Lieber and Leslie Lee, who have both graduated, gone on to do wonderful things. Sarah is a GI fellow down south, and Leslie is a hospitalist, I think, at Montefiore. So I wish I could be here today, but the work you're going to see really reflects a lot of the hard work that we collaborated on together. So my goal today is to provide a brief overview of inpatient handoffs, some best practices, and some of the work that we did within the internal medicine residency program to improve our handoff practice. And I think this will be relevant to really any specialty, particularly as work hours continue to evolve in our academic medical climate. I do have one disclosure. I'm the principal investigator on a grant that is funded jointly between the Joint Commission and Pfizer on transitions of care, no products. It's really a quality improvement grant, and it should not impact anything I say today, but I do want to disclose that here. So my agenda for the about 20-25 minutes that I'll speak to you is to, one, review the best practices for inpatient handoffs briefly, knowing that I'm not going to be able to go in depth, but just to scratch the surface as to what we aspire to. Number two, give you some data from our survey of the medicine residents in 2014, looking for some practice gaps that we tried to address. Three, I'll walk you through our research and our findings. And then lastly, I'll speak about some areas for future work and our conclusions. So the learning objectives today, as you got in your program, are to recognize the components of an effective inpatient handoff and to explain the role of direct observation and a structured template in encouraging adherence to those practices. So first, let's speak about some of these best practices themselves. So as I'm sure we all know from our clinical practice, handoff is a game of telephone, right? And the number of people in that chain there has increased sequentially as work hours have become more and more fragmented. Certainly at least twice a day, and often more, patients are handed off from one provider to another, and that's just from day to night. There are numerous handoffs from ICU to floor, OR to floor, that all pose opportunity for medical error and harm. And if you look at data from the Joint Commission, if you look at the top bar here, this is a bar of categories of root causes of Sentinel events over the total number of events. And you can see that communication failure, by and large, drives the majority of Sentinel events that cause patient harm based on this data from the Joint Commission. So what does this tell us? It tells us that transitions are important, and I think we all know that, but this data here highlights just the magnitude of harm that can be done with poor care transitions. And really, if you look at all of the guidelines out there, they vary a bit in the way that they encourage you to hand off a patient, but they have four key components, and I've sort of put them on a matrix here. So on the top left, right, this is not working too well, a clear patient summary that delineates who is this patient here and now, not yesterday, not tomorrow, but what's active right now, right? What to do if bad things happen that are anticipated, so contingency planning. What's the action list? What things have to happen tonight or today or tomorrow? And then lastly, ensuring their synthesis. Does the receiver understand what I'm saying as the handoff giver? And really, the thought is that these four things together, if done briefly and effectively, can ensure patient safety during a transition of care. So one example of a society guideline that I like that sort of brings these things together is from my professional society, Society of Hospital Medicine. And I've taken there's 12 recommendations, and I've grouped them. So again, we want to give time and space for handoff and prioritize it. We want to make sure it's interactive, and that gets at the synthesis from the last slide, so it should be dynamic. We want to make sure that we include every patient, every active issue, every up-to-date piece of data, and everything that needs to be done during that shift. So it should be comprehensive. And I think getting at what we try to do in this project, this needs to be practiced. This is not something that you can do just sort of off the cuff your first day of internship. This takes cognitive skills of synthesis, of making a problem list, of taking clinical uncertainty and distilling it down into a meaningful nugget to hand off to someone else. And our goal in this project was to help our house staff do that. So we know that doing this reduces errors. I'm not going to belabor this. I'm sure we've all seen this paper, but this was the IPASS study in the New England Journal from the pediatric literature, a multi-center study looking at preventable medical errors with the implementation of a bundle of interventions. So not just a handoff template, but a rigorous educational program that would target some of the cognitive skills that I spoke about. And by doing so, you can see that there was, as highlighted in pink, a clear reduction in overall medical errors, preventable adverse events, and near misses. So powerful multi-center data saying that this is indeed important and that we need to find ways to educate our residents to do this better. So in 2014, Sarah Lieber, she was a second-year resident then, and I sent out a survey to the medicine house staff, getting their feedback on a number of issues regarding handoff. And I want to highlight some of the practice gaps that came out of that survey here. And I'm just going to show you sort of the 30,000-foot view, given our time limitations. So this graph here shows the percentage of respondents that agreed with the following statements. So on the far left in the light blue, the statement is, I did not receive formal training in handoff best practices. 42% of people. That was scary to us. In the purple, I've witnessed active medical errors that I thought could have been prevented had I gotten a better handoff. Again, 42, 43%. And just over 30% felt that the current handoff tool, which was somewhat ad hoc and developed, to meet the needs of the users, was very poor or bad. So this gave us some evidence and some impetus to try to change things for the better. So here's what we did. So this is a brief timeline. So pre-intervention, we did that needs assessment that I spoke about, and we did some blind observations of handoff encounters using a tool that I will show you. And this tool is based off of IPASS. It's based off of the domains in IPASS, illness severity. Actually, let me go back to the slide because I'm having a senile moment here. Patient summary, the action plan, the situational awareness, and the synthesis, right? So again, those same 4 boxes on the matrix. And then, using that data, we implemented a new handoff tool, which I'll show you shortly. That's the middle column. And we gave consistent feedback using that same observation tool to every single resident every single time. And then we proceeded with some educational initiatives that I won't have time to speak about in depth, but really spoke to that synthesis, that cognitive skill that is so hard to do. And we tried to empower our residents to give feedback to their junior trainees just as we had been doing. So really the analysis I'm going to show you is between column 2 and column 3. Column 3 is harder to evaluate, but that was sort of the more cognitive piece. The quality improvement piece is what I'm going to show you now. Does that all make sense? Okay, let me check the time. So this was the tool that we rolled out in 2011. And really, you can see that it links up nicely with those 4 matrices. So there's a one-liner, so that's the patient summary, right? There are 2 things to do. We tried to limit the number of tasks that were signed out, if possible. And there were 3 take-home messages, one of which was the patient stability and some must-know facts. And then we developed a more robust contingency planning based on the survey data that we got from the residents about areas they felt they were ill-prepared to handle at night. And specifically, it was airway issues, neurologic issues, cardiac issues, some emergency contacts, fluid status, antibiotic choices. And we organized them in an A, B, C, D, E, F, G sort of pattern to make it easy to remember. You can see in the medical record, it is sort of a smart text that is auto-populated into every patient's chart, and this gets printed in the sign-out document. And I again just want to show the 4 elements I showed before. Those, while more detailed and more granular, each of the things we put in that handoff really fell into one of these 4 buckets. Again, patient summary, contingency planning, action list, and synthesis. So what did we do and what did we find? So we calculated for every handoff encounter a composite score. So basically, we evaluated each handoff for a number of behaviors that I'll show you in a minute out of 4 possible points. 4 is for every single patient on the list. 0 was for no patients, and 1 and 2 were gradations in the middle. And then we summed them and divided by the total possible number of points, which was 44 points. We did a pre-post intervention comparison and then did some exploratory analyses looking at a number of team-based factors, resident-based factors, and some other things I'll show you. And this is what we graded the handoffs on. And I'll just draw your attention to, again, the large categories. Did the team distinguish acuity, who's sick and who's not? Was there a clear clinical history and some specific points in there? Were the tasks clear and what to do with the data clear? Was there clear anticipatory guidance? Was there synthesis? And then of note, did they ask for questions? Was there closed loop communication? And hopefully, were there many distractions or not? Was it quiet? Things like that. And this is our data. So to walk through it, I'm just going to walk over here. So you can see that during the intervention period, the mean composite score was about 92.3% adherence to best practices, whereas at baseline, 72.5, and those are univariate analyses. All of this is univariate analysis. And you can see just the salient points that the major areas of improvement were the presence of the intervention, so the presence of that documented, consistent feedback, and the pace of the handoff that was subjective. An ideal handoff pace is better than slow or fast, right? Laboriously slow or rushed handoffs. And interestingly, handoffs that were conducted in a dedicated room is substantially better than those that were conducted in the hallway. And this was a real objective of ours after the clear visit, trying to make sure that we provide the adequate, appropriate space to protect, our residents so that they can have this time. And then we looked at also the number of patients per team. So if you had a hypothetical team with 0 patients, you started at 94.9%. And for every additional patient, you lost about 1.75% adherence, suggesting that the more patients we have, the more distracted we are, the worse we do. And the number of providers per team didn't really seem to make a difference. And of note, the patient-to-provider ratio didn't make a difference either. So it seems to be the census itself that drives this, right? Not the number of doctors or the number of doctors per patient. Does that make sense? And then lastly, this didn't actually make it onto my presentation, but we did a multivariate analysis to look at which of these things were the most strong predictors of good handoff practice, and it really was the presence of the intervention, independently of all the other factors. So again, what that says to me, that this really is the feedback that makes a big difference. Sitting down with people and giving them feedback about what their performance truly does matter. So what are the conclusions and what are the limitations, right? We found that a structured handoff tool and consistent evaluation and feedback does improve performance based on our scale. That said, a number of limitations to our work. Number one, this was largely a single observer. Number two, it was a small study, about 90, 100 handoffs over a relatively short period of time. And there was certainly some observer bias, right? I think we're probably less likely subconsciously to rate a handoff as very good if it was laboriously slow or laboriously fast. So certainly some limitations, and this process is very labor intensive, but the goal here is now to integrate this into the curriculum and empower residents to be doing this regularly for their learners. So some quick acknowledgements. I want to thank Sarah Lieber and Leslie Lee, the 2 residents that I worked with on this project, and Bridget Shaw and Julie Pearson, who were incredible mentors for me. This was my first QI project here as faculty at Mount Sinai, and I really appreciate their guidance as we developed this project and the education and the biostats methods. So thank you so much for your time, and I'd be happy to answer any questions.
All right. Hello, everyone. My name is Chang, and thank you for that introduction. And thank you for having me in this forum to share the research that we've done in simulation education. It's especially an honor to be here speaking to so many familiar faces, and slightly intimidating to talk to all my teachers from the past 8 years. All right. So for disclosures, I have none. And my objectives during this talk is to discuss the various uses of simulator in medical education, using the Department of Anesthesiology as an example. Next, I want to introduce the controversy surrounding the use of death in simulation. Then we will review the existing studies that are out there on utilizing simulated death as an educational tool. And finally, we will discuss the details of our study on the effects of simulated death on participants' attitudes regarding the simulation. So first, let's talk about the various uses of simulation in medical education. Simulation has become widely utilized in healthcare to teach critical skills and knowledge without putting actual patients in harm's way. There are many applications of simulation that have been mentioned in literature in virtually every specialty. This is by no means an exhaustive list, but simulation has been used to teach medical knowledge, to demonstrate delivering bad news, teach how to deliver end-of-life care, teach or evaluate ethical standards, and to foster technical skills, just to name a few. And our anesthesia department has certainly embraced the use of simulation in medical education in the past decade or more, and it is used to educate people at every clinical level. So and it starts with first-year medical students with physiology simulation. This is actually a picture of my classmates during one of those sessions, and I can't be sure, but I might be in the corner somewhere in the back. Then we are reintroduced to the department during our third and fourth year electives, where students can learn some of the basic concepts of anesthesia and also practice airway management skills during those sessions as well. Simulation education is continued for residents starting with our intern year. Our categorical intern year consists of rotations in medicine and surgery and other subspecialties, but 2 months of it are spent with the department in anesthesia and acute pain management rotations. And during those, our interns go through 3 to 6 scenarios of simulation to get a taste for basic anesthesia patient management, basically a taste of what's to come next in our subsequent 3 years. Then, at the start of our clinical anesthesia year, which is our PGY2 year, we undergo a comprehensive 7-week simulated course as part of our orientation to anesthesia training. And this includes introduction to induction of and emergence from anesthesia, as well as management of hypoxia, hypotension, difficult airway, and ACLS. We also receive periodic simulator sessions throughout the rest of our training, as general refreshers, as well as in specific subspecialties such as liver transplantation. Our use of simulation education isn't limited to trainees and extends to physicians and other healthcare personnel. Our simulation center is recognized by our National Anesthesia Society for maintenance of certification in anesthesia, which is one of the ways that anesthesiologists can maintain their certifications. The hospital insurance company anesthesia simulation initiative was started because the organization that provides malpractice insurance to various hospitals in New York City recognized the importance of simulation education and uses our department to provide simulation education to anesthesia attendings and nurse anesthetists throughout the city. The clinical anesthesia reentry program has been used to retrain anesthesia physicians who have been out of practice for various reasons. And this list doesn't include the various interactions our department has had with the rest of the hospital, whether it's training courses with LVAD nurses or Ebola training that took place in 2015. There are just some of the examples, and I'm sure I'm missing many of the activities that our department has been a part of. There are clearly many different ways, as this shows, to utilize simulation to train healthcare professionals of all levels and departments. So next, let's switch gears and talk about the controversy surrounding the use of death in simulation. The increased utilization of simulation has led to a growing debate of ethics surrounding the participant safety. One topic of such a debate is the use of simulated death as a learning tool during simulation. There are pros and cons that have been mentioned. Simulated death maintains the fidelity of the clinical scenario. It also allows the learner to experience a potentially rare event, and no actual harm is inflicted on the patient. The cons are the potential psychological harm to the learner after experiencing patient death. This can evoke feelings of loss and responsibility. There's evidence that stress can both be good and bad for learning. But much of this debate surrounds is based on expert opinion, and there's still little that we know about what the actual participants think about how experiencing death during simulation impacts their educational experience. So as I mentioned, there's not a lot in literature about the participants' actual thoughts. So our department conducted a literature review to see what is out there. And this is a study that's been accepted for publication. And that found 7 major prospective studies examining the use of simulated mortality. And here is a chart summary of those studies. I won't get into the specifics of each one, but rather present some characteristics and themes. The participant groups were solely residents or solely students in all these studies. And most of these studies involving residents had a small sample size because they're limited to a small pool of subjects of current residents. These studies had an N ranging from, I believe, in the teens to about 150. And they were conducted within different departments, including medical schools, pediatrics, anesthesiology, emergency medicine, and urology. All of them were prospective, and many of them were descriptive and used questionnaires to ask participants about their thoughts on their simulator experience after the experience. Some were randomized and evaluated performance, And of these, one of them found that death in simulation led to poor learning outcomes and increased stress. However, most of them concluded that death creates stress, but participants found the experience useful and were also found to perform better in the studies that assess performance after morbidity and mortality in simulation. So here's where our study comes in, and we looked at whether simulated death enhances attitudes regarding simulation. Our objectives were to establish a link between exposure to simulated death and learner attitudes regarding simulation. And our hypothesis was that the exposure to simulated death will actually positively affect learner attitudes towards simulation. So our study methods, we distributed anonymous surveys to participants of full environment simulation sessions at our simulation center from 2014 to 2015. And participants included medical students, anesthesiology residents, and anesthesiology attendings from multiple institutions. The demographic data that were collected were the participants' clinical level and the number of years they were in practice. And the simulation data that was collected included the number of scenarios that they underwent during the simulation session, whether any of those scenarios included an exposure to death, and the number of deaths that were experienced during the session. Whether they thought the simulation was helpful, whether the participants thought that the simulation will change their practice, whether the participants thought that simulated death can enhance learning, and their overall rating of the simulation on a scale from 1 to 5. We compared the demographic and simulation data for the group that was exposed to simulated death versus the group that was not. And we also ran a logistic regression analysis using the exposure to death and clinical level as the predictor variables with the simulator experience variables as outcomes. So in our results, 250 survey responses were included in our analysis. And of those, 64% were attendings and 36% were trainees. And 82% experienced death during simulation sessions and 18% did not. Here is a chart that shows the comparison of the subjects who are exposed to death during their simulation versus the participants who didn't experience death during their simulation. And as you can see here, there was a comparable number of scenarios that they went through during each session. The group that experienced death gave a significantly higher rating at 4.77 versus 4.5. And a significantly greater percentage of them were more likely to give the simulation a maximum 5 out of 5 rating, 83% versus 58%. A significantly greater percentage of them also thought that death can enhance learning, 75% versus 58%. And a comparable percentage found the simulation helpful and thought that the simulation would change practice. One thing that was also notably significantly different was the makeup of the groups themselves, where the group that was exposed to death had a smaller number of participants who were currently in training. So that's something that we wanted to account for and adjust for. So we ran a logistic regression model, and the outcome variables that we used were the simulation variables. And the ones that were significant were whether the participant thought that death can enhance learning and whether they gave the simulation a maximum 5 out of 5 rating. So the predictive variables that we included were whether the participant was exposed to death and whether the participant is currently in training. And this shows that for the first one that even when taking into account training status, those who were exposed to death were almost twice as likely to think that death can enhance their learning. And in the second one, even when accounting for their training status, those who were exposed to death were more than twice as likely to give the simulation a maximum rating. And of note, in the second one, it was also noted that those who are currently in training were less likely to give the simulation a maximum rating. So our strengths and weaknesses of the study. Strengths, we were able to compare the two groups, death versus no death, during the simulation sessions, which was not done in some of the 7 studies that we discussed before. We had a relatively large sample size because we were able to collect it for various groups throughout 2 years. And we also had a mixture of different clinical levels, including attendings and trainees. And we were able to do logistic regression to actually come up with quantifiable numbers instead of just reporting survey responses. Some of the weaknesses, we weren't able to randomize due to how we collected our data, and we didn't have a pre-simulation survey, and of course this was done in a single study center. And our conclusions were that survey participants who experienced simulated death were more likely to think that death can enhance learning and also give the simulation the highest rating regardless of their training level. And our study, as far as we can tell from the literature, is the only study that compared closed-ended survey responses of simulation participants at various clinical levels that was able to demonstrate that exposure to simulated death can positively affect learner attitudes regarding simulation. Still not much is known about exactly how participants feel, and we think that prospective randomized studies would be very welcome to add more knowledge to this field. And one thing that I thought was interesting was how there was a difference in how the trainees evaluated simulations, and that is something that we could also look into in the future. All right, and these are our references. And I also just want to acknowledge my co-investigators in the study, Andrew Goldberg and Adam Levine, who are here with us today, Doug Wetmore and Sam DeMaria, and also Benjamin Heller, who spearheaded the literature search that was mentioned. And I also want to just thank the Department of Medical Education again for having me here.